Good morning. Welcome to the third installation of the Coffee and Conversation with the American Society of Colorectal Surgeons. I am your host, Rob Amajoy. Be sure to check out our previous episodes. Today's episode is on balancing parenthood and surgery. Today is part one of two-part series. Be sure to tune in to part two on June 1st, 8 a.m. Central. You know, guys, this is one of the conversations I wish I had in medical school, residency, fellowship, or even in my early career years. Like we always say in surgery, that if you're not planning to succeed, then you're planning to fail. Jim Rohn, a great mentor of mine, always says, one must surely arrive. The question is, where? So hopefully throughout this two-part series, one will be able to understand options for fertility preservation, and when deciding to start a family, understand how to build allyship with your non-physician partner, and understand how to plan ahead. Our first speaker is Dr. from the University of North Carolina at Chapel Hill and a Master's of Public Health in Maternal and Child Health from the University of North Carolina. She completed her obstetrics and gynecology residency training at Duke University Medical Center and a fellowship in reproductive endocrinology and infertility at the National Institutes of Health in Bethesda, Maryland. Dr. McCarthy has special interests in male and female infertility, polycystic ovarian syndrome, in vitro fertilization. She has authored several peer-reviewed publications on reproductive and infertility topics and has presented her research nationally. She's honored to serve as a medical director of SGF in Atlanta. Interestingly, Dr. McCarthy was a lieutenant commander in United States Public Health Service, Commissioned Corps, and held the position of assistant professor of obstetrics and gynecology at Uniformed Services University of the Health Services. Our second speaker is Dr. Ostenfeld, Emma Ostenfeld, who joins us from Medical College of Wisconsin, where she is currently a senior rheumatology fellow. She completed her pediatrics residency at Medical College of Wisconsin, and she earned degrees in medicine and public health from the University of Kansas School of Medicine. Her academic interests include medical education and clinical quality improvement. She co-founded the Solidarity in Medicine Committee for the Pediatric Residency Program at Medical College of Wisconsin, which develops programming with the following mission statement in mind: to encourage residents to advocate effectively for themselves and colleagues as we pursue personal fulfillment and develop our professional identity in a more equitable medical field. Our panelist is Dr. Jarita Higgins. She's a board-certified private practice family physician, an author, and an artist. She's a prolific writer and author, and is best known for her author of the books MD Dreams, practical advice for every stage from pre-med to residency and beyond. The other book is Women Who Lead, Extraordinary Women with Extraordinary Achievements. It's a collaborative book that she co-authored along with 21 other women. So without further ado, let's bring in our first speaker, Dr. Desiree McCarthy.
Good morning to everyone, and thank you, Dr. Amayoji, for the introduction, and thank you for just allowing me to be here to speak on a topic which I'm just very passionate about. Obviously, I've chosen this as my career, but like you mentioned, we do not get this education in medical school or residency, and so I'm always excited for an opportunity to just share from my perspective, just what we can do to build our families now or in the future. So I'm going to share my screen. And here we go. Okay, and let's see. I can minimize everyone. Okay, so Fertility 101 is what I'm here to talk about. And as Dr. Amayoji mentioned, also fertility preservation if we're not ready to be pregnant. You already heard about me. So I'll just jump to, first, there are common fertility myths, and we have to be conscious of these and dispel these. The first largest myth is that infertility is a female problem. And what we really recognize and understand is that male and female fertility exist in equal incidences in couples where there's a male partner present. So we always evaluate a male partner and don't just focus on a female evaluation. Many women feel like if they're healthy, their age doesn't matter as much when it comes to fertility. And you'll see a little bit later in my presentation that age is a significant factor for female fertility. Many people think that fertility treatment is too expensive or not affordable, and that's not always the case. We also often think that fertility treatment means IVF automatically, and we have other options other than just IVF. For women and couples going through infertility, it can be isolating. They can feel alone. They can feel ashamed. They can feel like they're the only ones that are having trouble, and that's just not true. But that's a common sentiment that I hear from my patients. Many people also think if you go through fertility treatment, that means you're automatically going to have multiple pregnancy. That scares some people away. That attracts other people who want a multiple, or we get many requests for couples who want to have twins and expand their family faster. And then when couples are trying, advice from well-meaning friends and family members of just relax and you'll get pregnant is not only not helpful, but it's just not true. There are fertility factors that we need to identify and address when there is a fertility concern. So the reality is that infertility is more common than we appreciate. 1 in 8 couples of reproductive age will have difficulty getting pregnant when they're ready. And so what that means is that everyone on this call either knows someone or who has experienced infertility or trouble conceiving themselves. And as I mentioned, an equal number of men and women have infertility. So how we define infertility is really based on the female partner's age. And so infertility is the inability to conceive in a specified period of time related to the female partner's age. And again, in a few slides, you'll see why the age is significant. But for women who are under 35 years old, having regular cycles, having unprotected intercourse, we consider infertility if they've tried for 1 year and have not conceived. For women who are between 35 to 39, we shorten that time frame to 6 months of unprotected intercourse. And once a woman is 40 years or older, we shorten it even further to 3 months of unprotected intercourse. If they have not gotten pregnant, then it's time to seek a fertility evaluation. What we also understand, there's recent reporting on the incidence of infertility in female residents, particularly female residents in surgical programs. And what we've observed is that female residents have twice the risk of infertility compared to the general population. Their age of diagnosis is relatively young, at 33 years. And what we find is that 1/3 of them already have a decrease in their ovarian reserve, even though they're younger. Due to the extensive training and the time commitment of a surgical residency, what we also have observed is that when female residents are ready to conceive, they're older. They're on average 10 years older at the time that they have their first child. Because they've delayed their family building, they have fewer children overall. And then also because of advancing age, high stress environment, they also have higher obstetric complications when they do conceive. One way that our practice is attempting to address this is that we have recently developed an egg freezing program for surgical residents where women in surgical specialties or surgical residency programs can go through an egg freezing or fertility preservation cycle at a discounted rate. So to encourage them to freeze their eggs if they're not ready to be pregnant now. I'll talk more about egg freezing in a little bit. So just the basics. When we're thinking about infertility, it always goes back to the basics of sperm, eggs, and anatomy. And that's where our basic evaluation always begins. If there's a male partner present, we will do a semen analysis, anatomic evaluation for the female partner, and then we can also assess egg reserve through several hormone tests. For sperm factors, we always complete a comprehensive semen analysis, which looks at the volume of semen, the sperm concentration that's present, the percent of sperm that are motile, and the percentage of sperm that have normal morphology. The majority of sperm, the turnover is very high. Sperm are produced every 2 to 3 months. And so when you look at a sperm on a grid, like you see in the bottom left, majority of sperm have abnormal morphology. Normal is considered at least 4% of all the sperm in a sample having normal morphology. So we do see many that have, 2 heads, 2 tails, abnormal shape to the sperm and things like that. The total motile sperm concentration is the total amount of sperm that's in a particular ejaculated sample. And so we have kind of goals of what those counts should be for natural conception or intercourse. The total amount of sperm ejaculated should be close to 40 million. If we're performing an insemination or intrauterine insemination, IUI procedure, we look for the total motile sperm count to be at least 5 million. If we're performing IVF or using ICSI, which stands for intracytoplasmic sperm injection, we can work with lower sperm concentrations of only a few per high power field, because we can take one sperm and inject it into each egg that we retrieve in IVF. So male partners should always be evaluated. For anatomic evaluation, we want to know, are the fallopian tubes open and is the uterine cavity normal? So we will perform an HSG or hysterosalpingogram, which is a flush of dye through the uterus and fallopian tubes under fluoroscopy. We can see a nice contour of the uterine cavity, and we can see the contour of the fallopian tubes and observe for spill of fluid from the distal ends of the fallopian tubes. We're also able to observe if there's a hydrosalpinx, a tubal occlusion, or fluid in the tubes on an HSG. We can also see if there's an abnormal shape like a bicornuate uterus or a Mullerian anomaly of the uterus on an HSG. And then we want to assess the uterine cavity with an ultrasound, often with saline infusion, to again evaluate the uterine cavity in 3D. We can assess for fibroids, adenomyosis, and things like that, which may also impact fertility. As I mentioned, age is a significant factor for women, and it's because of the decline in our oocytes from in utero. When we're about 20 weeks gestation, there are 6 million immature primary oocytes in the fetal ovaries. By the time we are born, we have decreased to about 1 million oocytes. And as you can see, there's a slow drift from birth forward that by puberty, there are 300,000 oocytes remaining in the ovaries. There's a sharp decline in the mid-30s towards menopause. And by menopause, we have roughly 1,000 oocytes remaining in the ovary. Despite that decline, there are only about 400 eggs that are ovulated in a lifetime, but there are many oocytes that start to develop with each menstrual cycle, and then one that ultimately develops. But with the start of a cycle, there are 50 to 100 primary oocytes that start to form, and then ultimately one of those will ovulate. The rest of those go through atresia, and that is the explanation for this sharp decline from 6 million oocytes in a fetal ovary to 1,000 by menopause. In addition to the egg number decreasing, the egg quality is also affected by our age, as reflected here. We are born with these oocytes, so as we age, the eggs in the ovary are also aging. The age of the ovaries determines how likely the egg is to fertilize, but also if the embryo will have a chromosomal abnormality or not. And what we see is that when women are under 30, the risk of a chromosomal abnormality, often leading to early miscarriage, is about 15%. But there's a sharp rise into the 30s and 40s. And by the time we are 45 or older, over 90% of embryos or pregnancies will have an aneuploidy or a chromosomal abnormality. And you can see the table on the right also. The risk of a chromosomal abnormality increases from 1 in 385 in a 30-year-old to 1 in 21 by the time a woman is 45. And again, the most likely outcome of those abnormalities is an early miscarriage in the first trimester. But depending on which chromosome is aneuploid, it can also lead to an aneuploid pregnancy or a live birth with a Down syndrome, a Turner syndrome, and those type of conditions. And so combining those together, the decline in egg number is responsible for the blue curve where fertility slowly drift down. from the early 20s until 45 plus. And at the same time, the orange curve shows the steady increase in the risk of miscarriages due to ovarian aging and changes in egg quality. What you see is that these curves intersect around age 40 and become very sharp in opposite directions from there. So when we're talking about fertility or thinking about it, we have to be conscious on the left side of these curves. This is the time to plan for your pregnancy, to prepare to get pregnant while you're there, or to think about ways to collect your eggs at that younger age so that you'll have a more favorable chance for pregnancy when you're ready. When we talk about fertility treatments, we have kind of two pathways that we go in general. You can have ovulation induction or superovulation agents, which are oral, Clomid or letrozole. Clomid is a selective estrogen receptor modulator or SERM, and then letrozole is an aromatase inhibitor. These are pills that a woman can take to stimulate a follicle in the ovary to develop and to ovulate on a kind of standard schedule. For women who don't ovulate regularly, most commonly due to polycystic ovary syndrome, these pills can be used to induce ovulation or to stimulate an egg to develop. For women who are already ovulatory, these same medications can be used to superovulate or stimulate an additional follicle or two to develop. And with those medications, we combine them with either timed intercourse or with an insemination procedure. Our other treatment option is IVF or in vitro fertilization, where we replicate the fertilization process that naturally happens in the body and take that into our laboratory. We stimulate the ovaries with injectable gonadotropins of FSH and LH, similar to what's produced by the pituitary, to stimulate mini follicles to continue to develop instead of going through atresia at that cycle. Eggs are retrieved under anesthesia and fertilized in a laboratory. Eggs and sperm are cultured together in an incubator until they develop into embryos. We have embryos that we can transfer to the uterine cavity. We can freeze embryos for the future. We can perform PGT, which is genetic testing of an embryo to screen for genetic traits or aneuploidies before an embryo is transferred back. For women who are thinking about the age effects of their fertility but not ready to be pregnant, we also discuss fertility preservation, which can be performed electively or for some women as an oncofertility preservation. So egg freezing is a way for us to take advantage of that curve. If we're not ready to be pregnant, we can collect eggs at a younger age and freeze eggs at that age. The benefit of egg freezing is that the chance of pregnancy and the potential of those eggs is based on the age when they're frozen, not the age when they are thawed and returned to the body. And so with egg freezing, again, very similar to the initial phase of an in vitro cycle, a cohort of eggs are stimulated through injectable gonadotropins to develop and mature. We extract the eggs and then we freeze them until they're ready to be used at a later time. When eggs are frozen, they can be frozen indefinitely. We have seen significant improvement in freezing techniques for eggs and sperm. Previously, eggs were frozen with a slow freezing method that would allow ice crystals to form, and that could sometimes be damaging to the cells that were being frozen and then thawed later. The newer technology is to vitrify, which is a very rapid freezing technique that does not allow for that ice crystal formation, and so the integrity of the frozen eggs and embryos are intact and not affected by that freezing process. Again, they can stay frozen indefinitely, and there's no time frame that they have to be thawed in to be viable and used. A survey of 500 women who froze their eggs identified that the majority of women who froze because they were single and didn't have a partner at the time. But a significant percentage of women also mentioned professional reasons as a reason to freeze, career and education and things like that. And then there's also a financial reason that some of them may postpone having their children at a younger age. The American Society for Reproductive Medicine lifted the experimental label from egg freezing in 2012. The first birth from a frozen egg was performed or delivered in 1986, and then The technology was no longer considered experimental in 2012. Follow that up in 2018, ASRM then determined that elective egg freezing was also ethically permissible. And because of that, what we've seen is a huge increase in the incidence of egg freezing in this country, from 500 cycles in 2009 to over 17,000 in 2020. And we have continued to see greater interest and more egg freezing even since then. When we think about egg thaw outcomes, we always recommend that women freeze at least 20 to 30 eggs, because first we kind of pause in the middle. We don't know the potential of those eggs until we thaw them later. And we also understand there's an attrition from an egg being frozen until it's thawed and fertilized. And so what you can see here is a comparison between eggs that are frozen under 38 years and eggs frozen 38 to 40 years. When eggs are ready to be utilized, we have to thaw them first. There's a post-thaw survival of 80 to 90%. When eggs and sperm are combined in the laboratory, about 70% will fertilize. And then a quarter to a third of the fertilized eggs will progress all the way to a fully formed blastocyst, which is a high quality embryo. So what you see is if we're under 38, 10 frozen eggs will result in roughly 2 high quality embryos. Those numbers shift a little bit once we're closer to 40, and so 15 frozen eggs will yield 2 high quality embryos on average. And what that means is that many women will need to go through more than one cycle to freeze enough eggs to get to 20 or 30 eggs. What we've observed is on average for women up to 40 years old, she will collect 13 mature eggs in one cycle. And many women will need 2 or 3 cycles to get to 20 eggs to bank for the future. There are associated risks with egg freezing as well as in vitro fertilization. These risks affect less than 2% of women going through the procedure, but we always recognize and discuss those. Ovarian hyperstimulation syndrome is where many follicles can develop at one time, high estrogen levels, and women can become symptomatic from that in the short term. The ovaries are stimulated and enlarge from 2 centimeters at normal size, and they can enlarge to 6 to 8 centimeters during the stimulation. So that can increase the risk for ovarian torsion, which we see very infrequently. There can be procedure-related complications due to daily injectable gonadotropins. Egg retrieval is performed under anesthesia. The follicles are aspirated of the eggs with a transvaginal needle, and so there's risk of bleeding and just procedure-related complications there, but again, very low risk. And most important, we have no evidence that there's an increased risk of cancer or impact on future fertility for women who go through fertility treatment or egg freezing. As I mentioned, eggs and embryos can be frozen and stored long-term. They're stored in liquid nitrogen. They can truly be stored indefinitely, and the success rate and pregnancy rates are based on the age when the eggs were frozen, not when they are returned to the body. Again, when we freeze eggs, we thaw, we combine with sperm in the laboratory, and then we can proceed to an embryo transfer after those eggs have cultured. And I just like to end with this beautiful slide of human embryo development. And this is what we observe in our laboratory every day. And I think it's still just a cool slide to see. So the top left is a fertilized egg. You can kind of see 2 little depressions or impressions in the center of that egg. Those are the nuclei from the egg and the sperm. So this is how we can tell that an egg is fertilized after sperm and egg are combined. So that's called a 2 pronuclei. From there, that single oocyte will cleave into 2 cells and cleave, so that the next image is 3 days after fertilization. A cleavage stage embryo is a cluster of 6 to 8 separate cells that continue to divide and develop, and then you go through the stages there of a morula formation. Bottom left continues to develop, and the bottom center is a fully formed blastocyst. The density at about the 11 o'clock position is the inner cell mass. You can see the cells around the perimeter of the embryo become the trophectoderm or the placenta. And in the last picture, bottom right, this is a hatching embryo. So that little shell that remains behind is the zona pellucida. And the embryo actually has to hatch out of that zona pellucida, leave the zona pellucida, that shell, behind. And then the hatching embryo is what attaches to the uterine wall for an implantation. So this is what we observe in the lab. And this is what we can do with frozen oocytes. We can do this with real-time fertility treatments. And so we always just want to think about fertility. We always want women to have a plan for their fertility, the same way that we plan for our education and our career. We want to keep this on the radar as well. You have options for fertility evaluation and treatment if you're ready to be pregnant now, or for fertility preservation in the future. Again, I'm medical director of SGF Atlanta Shady Grove Fertility, and this is my contact information, and I welcome any questions as we wrap up after the next speaker. Thank you.
Wow, thanks so much. Outstanding talk there, Dr. McCarthy. Very nice review.
Thank you.
You've just heard Dr. McCarthy Keith talk about Fertility 101, testing, treatment, and preservation. I've learned so much. You're listening to the Coffee and Conversation with DEI of American Society of Colorectal Surgeons. For those just joining us, I want to remind you that there will be an open for Q&A at the end of the presentations. Without further ado, our next talk is on reproductive health and for medical trainees by Emma Ostenfeld. Thanks so much for that.
Okay, thank you so much. Please let me know if you're having any trouble hearing me. So I'd love to start my part of the talk by putting this in context of burnout, because I think there has been widespread recognition of how important this idea is when we think about how physicians can remain engaged and fulfilled throughout their careers. This was a survey of over 7,000 physicians, and the researchers classified them by the number of years they had been out of training and in practice. So the first group, early career, practicing for 10 years or less, middle career, 11 to 20 years, and late career, practicing for 21 or more years. And they found significant differences in the dimensions of burnout that affected these three groups. Early career physicians had the lowest satisfaction with their career choice to become a physician. They had the highest frequency of work-home conflicts, and they were the least likely to feel like they could resolve the conflict while meeting both the home and work responsibilities. Middle career physicians worked more hours. They had the lowest satisfaction with their work-life balance, and they had the highest rates of emotional exhaustion and burnout. They were also the most likely to plan to leave medicine for reasons other than retirement in the next 24 months. Late career physicians were generally the most satisfied and had the lowest rates of distress. So I take away from this that early practice is a high-risk period for burnout. This figure shows the key drivers of burnout, but it can also hold the solutions, as when these dimensions are optimized, we see greater physician engagement. I want to highlight just a few that are relevant to our discussion today: control and flexibility, work-life integration, and social support and community at work. My own experiences tangling with some of these drivers as a resident led me and some partners to form the Solidarity in Medicine Committee. We are a group of medical trainees and educators who gather with this mission statement in mind: to encourage residents to advocate effectively for self and colleagues as we pursue personal fulfillment and develop our professional identity in a more equitable medical field. One of our sessions explored the book Lean In by Sheryl Sandberg. She shares excellent data about gendered differences in professional advancement. For instance, women now earn 57% of undergraduate degrees and 60% of master's degrees. In 2019, the AAMC reported that women now comprise 50.5% of medical school students. This is not a new phenomenon. As you can see, we have achieved roughly 50-50 sex distribution among medical school graduates for the past 20 years or so. This figure comes from the State of Women in Academic Medicine report in 2019. Even though we've made excellent gains at the medical school level, as you move up each rung of the ladder in academic medicine, the proportion of women in each of these roles shrinks dramatically to just 18% of department chair and dean positions being filled by women. Academic gains have not translated into increased numbers of women in top jobs. The pipeline is full of women at the entry level, but not in leadership. I want to take you back to the study where we said late career physicians were the most satisfied and had the lowest rates of distress. And now I want to show you the demographics of this population. It's very similar to that figure from the AAMC. Early career physicians are roughly divided evenly between sexes, but by the time you make your way to that late career stage, again, just 18% of those happy, most satisfied physicians are female. I think this makes the case that our system hasn't changed sufficiently to accommodate a rising percentage of women staying in medicine and rising to leadership, which is where those systems level changes are made to make it easier for the next generation of female physicians to rise in that way if they want to. So after that session, I had my eye out for papers on similar topics, and this title grabbed my attention. Female physicians earn an estimated $2 million less than male physicians over a simulated 40-year career. This data came from a very large survey conducted through Doximity. And the researchers found that differences increase most rapidly during the initial years of practice. So on average in the first year, men are earning about $10,000 more. Sorry, didn't want to go. And then, roughly $42,000 more in the first year. And by their 10th year, they're earning roughly $90,000 more. So if you simulate those differences out over 40 years, that's where that $2 million gap comes from in salary. This difference is there despite controlling for hours worked, clinical revenue, practice type, patient volume, and specialty. I will note that there's the narrowest salary gap in the primary care fields, and it's the widest in the surgical fields. I liked this commentary on the paper from Dr. Jane, a critical care physician at Yale, who said, "These findings are distressing yet unsurprising. Women physicians who are in the prime of their reproductive years when they start practice experience insufficient maternity leave, inadequate support on return to work, and a disproportionate burden of childcare in the subsequent years." For female physicians, there's this inescapable intersection between a critical time in our medical training and establishing early practice and the prime of our reproductive years. How does this overlap shape the rest of our personal and professional lives? This was a survey of female residents across 27 OBGYN programs. They found that 81% of the residents desired at least one child, and 54% were delaying pregnancy at the time of the survey. Of those delaying, 85% said it was due to career/education. 66% of the residents were concerned about future infertility, and they were more likely to worry about that if they wanted to pursue a fellowship. 37 had considered or completed fertility preservation, and just 1% of the residents had actually undergone cryopreservation or egg freezing. The authors point out that the average age of their cohort was 29.7 plus or minus 2.2 years. As we just learned, that's primarily in the peak fertility window for women, whose fertility may begin to decline at age 28 years. This has been studied specifically and more broadly among surgical trainees. This survey spoke with over 200 residents, mostly female, whose average age was 32.2 years. When asked about any previous education or exposure to information about fertility planning and fertility treatment, just 12% had gone through any discussion about this. When it comes to insurance coverage for fertility treatment, only 30% of the residents were aware if they had such coverage, and of those who did know, only 26% reported having coverage. Exposure to education about fertility preservation is even worse, as just 5.1% of the surgical residents had received any information about this. You see a similar major insurance coverage awareness problem too, where the vast majority of residents and fellows don't know if they have any coverage for fertility preservation. And of those who do know, just 12.5% say that they have it. Similar to the OBGYNs, just 2.6% of these residents had pursued fertility preservation and training, but 33% say that they would if they had insurance coverage for it. The authors share this comment. While oocyte preservation gives female surgical residents autonomy and additional options in family planning, it is not a direct solution for the problem culture that discourages childbearing during surgical training. Programs have the duty to educate, empower, and advocate for female trainees to have more control over their reproductive decisions to foster gender equality in the workplace. As my colleague, Dr. Desiree, was mentioning, surgeons have good reason to be concerned about their future fertility. This survey spoke with over 1,000 surgeons, you can see from a broad range of the specialties. And they compared the rates of fertility difficulty and use of services between women surgeons and the general US population. This figure shows fertility outcomes among female surgeons in blue and the general US population in red, which was gathered from CDC and NIH reports. 32% of women surgeons report having difficulty with fertility, compared to 10.9% of the overall population. 27% of female surgeons need to use fertility services, compared to 11.9% of the overall population. And 23% of female surgeons use assisted reproductive technology, compared to just 5.2% of the general population. On average, the female surgeons had 1.4 biological children versus the national average of 2.6. Their age at first pregnancy, on average for female surgeons, was 33 years, compared to the national average of 23 years. And they found the highest rates of infertility varied by specialty. The biggest was in otolaryngology at 29%, followed by general surgery at 22% and ortho at 18%. In this survey, the women who had fertility difficulty, not surprisingly, were more likely to say that they would have preferred to have had additional children, 45%, versus 27% of those with normal fertility who expressed that preference. And they also would have preferred to have children at a different point in their career, almost 60% versus 29%. The authors comment here that physicians have legitimate reasons for choosing to delay childbirth, but clearly the consequences of this delay could be life-altering for many women. Less legitimate in our modern times of equal opportunity are concerns within one's residency. Residency programs must build more capacity to allow for pregnancy, particularly, can't get around it, as that is likely the best biologic time for women to consider pregnancy. Are trainees able to make informed decisions about this planning because they are aware of the risks of fertility? This was a survey of 65 trainees who attended an education session on age-related fertility decline and fertility preservation. 40% of the attendees expressed both personal and professional interest in fertility preservation, but the barriers to doing so for them included finances, time, and being unsure of what the options were. The researchers also administered a knowledge pre- and post-test around the session, and they found that the medical trainees were likely to overestimate the rates of per-cycle conception and underestimate the rates of miscarriages at younger ages. So essentially, they're a bit overly optimistic about how easy it will be in the future to become pregnant and carry a healthy pregnancy to term. Clearly, this may pose difficulties for them in personal decision-making later on. After the intervention, 98% said it was important for medical trainees to be informed about age-related fertility decline and elective oocyte cryopreservation. And an additional 15 to 20% said that they would now consider fertility preservation or consider recommending it. Ultimately, fertility issues are important for all physicians hoping to start families, whether they're male, transgender, single, or have same-sex partners. Physician reproductive health, including the ability to build a family if and when a physician chooses, is a vital aspect of well-being. Institutions should contract with insurance providers to offer coverage that defrays the steep costs not only for fertility treatment, but also for cryopreservation. I wanted to know what those steep costs looked like, so I found this figure from the Kaiser Family Foundation in 2020. These show the average out-of-pocket costs for many of the common fertility interventions that we do. The green bar shows the average cost per person, and the blue shows the average cost per successful outcome. So for instance, for IVF, you can see the average cost per successful outcome is over $60,000. When we think about a resident salary, I think anyone would agree that these costs are steep. How are American employers in general thinking about this? This survey asked employers about the healthcare coverage that they wanted to offer to their employees. They found that 53% were putting more emphasis on maternity and fertility as a specific clinical area to improve member health and reduce costs. When asked why they wanted to do this, the number one answer was to support their organization's inclusion and diversity objectives. The second was to recruit and retain talent. So they're not just thinking about this as a moral obligation, but it's also considered a smart business strategy. I want to give you a little bit more data about what our peers in other industries are looking at in terms of fertility benefits. It probably won't surprise you that the big tech companies in the Bay Area are some of the leaders in this work. Facebook will give $100,000 for 4 cycles of IVF. They also have general surrogacy benefits. Google helps with 3 cycles of IVF, as well as egg freezing. So that's not a shock, but I was surprised that Starbucks will give up to $10,000 per adoption, surrogacy, or artificial insemination, and they have a generous IVF benefit. Chobani covers 6 weeks of 100% paid leave after an adoption. They give 3 rounds of IVF, and they also have fertility preservation coverage. And employees at Lowe's receive coverage for IVF, help with frozen embryo transfers, and other fertility interventions. So I looked up my policy at the Medical College of Wisconsin, and you can see that infertility treatment is listed under services your plan generally does not cover. So we have room to improve in this area. So after you address the issue of fertility, we have to think about parental leave. The American College of Surgeons strongly endorses at least 6 weeks of paid parental leave for either or both parents. They say that these kinds of policies are insufficient if you don't have program-level strategies that provide schedule and clinical duty adjustments for pregnant trainees without engendering resentment from their colleagues. And it's not just the female partners who worry about this kind of resentment. This study interviewed 15 male residents across 4 general surgery programs. These men perceived that there was a greater stigma against them taking parental leave compared to their female colleagues, often connected to the obvious difference in the need to recover physically from delivery. They thought their paternity leave policies were vague, poorly defined, and arranged on a case-by-case basis, with the residents often needing to scramble to find their own coverage. Many of them had also encountered faculty comments, things to the effect of, well, when I was a resident, I didn't get to take any time off. And these comments are not so subtly enforcing traditional paradigms of prioritizing work over family. So now these male residents have to choose between feeling guilty about pausing their surgical training or guilt about not being there to bond with their new baby or to support their partner during such an intense time. Beyond parental leave, there's of course the question, is residency as it's currently structured compatible with parenthood? This is an excellent summary from 2013 that summarizes a lot of the research that was done in this area going on 20 years ago. In 2004, a Stanford survey asked, what is the highest priority need to improve the career success and well-being of female faculty? The women answered, a flexible work environment with regard to child or elder care, including access to available emergency childcare on site or near the medical center. In 2008, a Vanderbilt survey asked residents and fellows if a hospital-based childcare option would influence their choice between 2 otherwise equal programs. 71% said they would rank the program with hospital-based childcare higher. So it seems to me anytime you survey trainees about their preferences for these services, there's a loud endorsement, yes, we want them. And it's frustrating that so little progress has been made over the past few decades. This was a nice summary statement that came out last year in pediatrics. Training institutions should give serious consideration to creating 24-hour on-site childcare and sick childcare centers, or actively facilitate access to these services in a convenient location for all residents who want them. I always have to bring it back to this idea of recruitment. It feels like since the pandemic, every CEO in America expressed new support for diversity, equity, and inclusion. But we have to think about this strategically. What can we offer to people in their late 20s and early 30s to make ourselves more competitive in the marketplace of recruiting a more diverse workforce? The reality is that for many of our colleagues, using assisted reproductive technology is plan A to start their families. And this is such a powerful way to put real action behind these statements that you truly want to create an inclusive environment. So I hope the future of solidarity medicine will allow us to advocate within all of our institutions for changes that can make life better during medical training and a career in academic medicine. To me, the highest priority needs are fertility benefits for trainees, on-site childcare, including sick childcare, and fertility preservation coverage. I've included my references here if you want to learn more about these topics. And this topic for today was adapted from a presentation that I gave at Grand Rounds at MCW last fall. So if you want to view that, you can use this link. And this QR code just lets me know who was here today. And it's also an easy way for you to share your contact information with me if you want to collaborate in the future on any of this work. Thank you so much.
Thanks so much, Emma. I had a privilege of listening to that talk you gave at FCW. What an eye-opening talk. So for interest of time, let's bring everybody in. Let's bring everybody in. I have lots of questions. So I'm sure our audience have questions as well. So the first question goes to Desiree McCarthy. What's the ideal age to freeze eggs, and how much does egg freezing cost to your facility?
Yes, so I just, age matters so much. I hate to just keep beating a dead horse, but the age for the lady and her eggs and ovaries is so important. So when we're talking about freezing eggs, the best age is before you have aging effects on your egg reserve, which is going to be your mid-30s or younger. So the ideal age to freeze is under 35. You can freeze into your late 30s and even over 40. The closer you get to 40, you need to freeze more eggs. As I showed with that attrition from how many eggs we start with until we have favorable blastocysts, you just have to freeze more. So if a woman is under 35, we recommend that she bank up at least 20 to 25 eggs. If she's close to 40, we recommend banking close to 30 eggs if she can. And again, many women are going to require more than one cycle to get there. The cost of egg freezing in general, it varies by clinic and by region if you have coverage or not. But in general, if it's out of pocket, an egg freezing cycle is going to be about $8,000 to do. The medications for egg freezing are the exact same medications that a woman would take for IVF. Those medications alone are another $7,000 or $8,000 oftentimes. So when you put that together, one egg freezing cycle with medicine plus treatment can be $12,000 to $15,000 to do. You also have to think about once the eggs are frozen, there is a storage fee for the facility or the clinic to keep them stored, which can be, $700 or so a year of annual storage, which may be multiple years that has to be factored in when they go through those type of treatments.
Wow. Can you test the genetic health of the eggs and embryos?
We get that question a lot. So we can't really test the health of the egg beyond what I've mentioned. So you can look at a woman's age, you can check her AMH, you can check her FSH, and also we can check the follicle count or just the number of eggs that are developing in the ovary. That's how we kind of assess the reserve. What we can assess genetically is the health of the embryo. So PGT is pre-implantation genetic testing. And that's where, when I showed that last image of a developing blastocyst, when embryos culture all the way to the blastocyst stage, we can biopsy some of those trophectoderm cells, and we can run a karyotype on that biopsy and get a full karyotype for each embryo that we test. PGT is usually discussed more for women who are advanced age. Again, you saw the risk of chromosome abnormalities and miscarriage increasing in the mid to late 30s. So in those scenarios, you could do PGT on the embryos. And once that report comes back, we can selectively thaw a euploid embryo, transferring that to the uterus. And the pregnancy rates are going to be much higher once we know we have a chromosomally normal embryo.
Interesting. So Dr. Ostenfeld, this is for you. What drove you your interest into this topic? Because you're a pediatric rheumatologist.
I know, I'm sticking out in this surgery meeting. So I had my personal experiences as a pediatric resident married to an ENT resident. And there were so many times during my residency where I was thinking about how would we make this work? If I had a baby and I'm on nights and he's on call, who's taking care of this child? And it really frustrated me that there weren't more formal discussions about this as we go through medical training. So I was at a subspecialty interest group meeting one day, and one of our faculty mentors made a comment. She said, when I was in fellowship, my husband and I realized we weren't going to be able to put money away for the future because we had to pay for childcare. So that's just another thing that you want to think about in fellowship. And my co-resident Merritt and I were just like, finally, someone is talking about this kind of practical advice that we feel like we need to make these informed decisions about the future. So that sort of unleashed us to set up a more formal structure to get this kind of practical mentoring that we were looking for from our senior colleagues.
Wow. Yeah, I'm really glad that you guys are on. And what are the issues that you're exploring with your solidarity in medicine community? You know, every time I was operating last night or yesterday evening, I mentioned solidarity, and the residents like, what's that? The colleagues like, what's that? So can you talk a little bit about that and what issues are you exploring?
Yes, we chose that name specifically because we don't feel like this is just an issue for female physicians to think about, because as we've been talking about today, it affects all of us. And we wanted everyone to feel welcome in that conversation for anything that can just build greater solidarity among medical trainees and help acknowledge what it means to be a human being in your 20s and 30s going through this experience. So some of our other sessions have included seeking professional fulfillment. It's based on this book, Dark Horse, which I couldn't recommend more, where you learn how to seek out professional opportunities that are most likely to yield fulfillment for you. And that is how you achieve excellence, rather than the traditional model of, well, once you achieve excellence, you'll find fulfillment as a natural consequence. We know it doesn't always work like that. And then we also have sessions about standing up for each other, where if you are sort of on the receiving end of maybe a sexist or a racist comment, and the person next to you probably has a better chance of being able to use their voice to just question that, say, that's not really appropriate. Can we address that a little more? And so we want to be able to be active allies, but we find we need practice to build up that muscle so you can do it in the moment, because it's really hard when you're in one of those tense scenarios. So those are some of the events that we do.
Wow. So guys, obviously we have a bunch of unicorns experts here. I encourage you to try to get their information by the end of this talk to collaborate with them anyhow, any way, shape, or form. Dr. Higgins, you've been quiet. So you obviously a very busy family practitioner in private practice. You are very passionate about this topic, considering you wrote the book, MD Dreams in quotation. What is your story and your journey? How's it been so far?
Okay, so funny enough, I'm a family practice doctor now, but I actually did a prelim surgery year. And let's see, I probably was, I think, 29 when I was leaving the prelim surgery year and going into family practice. I think I met my husband, who was my boyfriend then, at about 30. And I fell victim to a lot of the myths that Dr. McCarthy was talking about. I thought because I was young and healthy that I had more time. I thought that I could get pregnant anytime that I wanted to. I thought that it was too expensive. Egg freezing kind of wasn't really a thing, or it wasn't really something that a lot of people that I knew did at that time. So I just assumed that it was too expensive. I didn't look into it. I assumed I'd be able to get pregnant whenever I wanted to. Long story short, I was focusing on planning all the other things, planning career, financial planning. You know, at the same time that we are giving talks to residents about financial planning, paying off loans, deferments, all of these things, we should be talking to them about family planning and how you don't have as much time as you think you have. You need to get on the ball with your fertility treatment. As I was doing all of these things and moving from state to state and trying to solidify my practice, I really should have been exploring fertility treatments at that time. So we don't have any children now. I'm 46, so the age for fertility has passed. So most likely we'll have to adopt, but this is my clarion call to look into it as soon as possible while you're still young, even if there's no partner in sight.
Thank you for that. Thank you for that. I totally agree with that. So this gets me to the next question, Dr. Desiree. I'm sure our audience, I want to know what lifestyle factors affect fertility.
You know, it's so important to have a foundation and a good starting place for pregnancy and just general health. And so we always start with that when I'm doing a consultation with a woman or a couple. You know, managing chronic conditions, if there's diabetes, blood pressure, you have to make sure that those are controlled. Managing our weight, what Dr. Hagen's mentioned, you know, I'm kind of reading between the lines, but there are disparities in fertility, reproductive care, reproductive outcomes. And for Black women, for minority communities, we do worse with our fertility outcomes. We access treatment later. We have less awareness. We have cultural barriers that keep us from getting there. We're not even approached in the same way. So the campaigns for fertility treatment, egg freezing, didn't reflect us. They were not ethnically diverse. So when you saw posters and advertisements, if you didn't see yourself reflected in that, then you said, then I probably don't need to be freezing my eggs. They're talking about someone other than me. People who look like me don't freeze their eggs. They don't do fertility treatment. So we have to address that. And so just getting back to the question, you know, healthy weight, normal BMI, blood, you know, A1C controlled, blood pressure controlled, and also, you know, exposures. Smoking can accelerate that aging curve for the ovaries and makes it go faster. The risk of ectopic is higher for women who smoke. Fertility is delayed for women who smoke. Men who smoke can have effects on their sperm function, motility, morphology. And these effects come from direct smoking, but also secondhand smoke. So we always talk about exposures, lifestyle, and just awareness and getting ready for fertility treatment so that you have a better response to treatment and less risk of pregnancy complications once you are pregnant.
Thank you. That's interesting. So, Emma, do you know how training program leaders feel about these issues? Like, what have you heard?
Yes, there's a lot of great research about that. For instance, I've seen work done in OBGYN where one study found that over 80% of program directors thought having a child during residency negatively affected the resident's performance. But I love these researchers. They're always great to pull in other data that says, no, there's been found to be no difference in case numbers between residents who have a child during residency and those who don't. So it plays into that stigma piece, but there's often not a lot of hard evidence to go behind it. There was a large survey of all ACGME program directors, and they found that roughly half of them think it's important to increase resources for residents who need fertility treatment or who want to do fertility preservation. So to me, that's a bit of a coin flip if you happen to have a program director who thinks this is an important issue. But sadly, the majority of program directors don't know if their program has insurance coverage for fertility treatments or fertility preservation. So that's such a go-to person for the trainees to ask when they have these kinds of questions. And if they're not aware of whether or not their program has coverage, it seems less likely that their trainees are going to take advantage of these services or advocate to have them covered. So I think there's certainly an awareness gap there. I think if more program directors were aware of the time pressure of this issue, they would probably be more interested in supporting trainees to get these services.
So we have a couple of minutes, but I'm going to ask one more question. Are you aware of any programs that have successfully implemented on-site childcare?
I am, yes. So at the Medical University of South Carolina, their pediatrics program set up a childcare subsidy for any local facility during the first 6 months of a child's life. And once they started that program, all eligible residents took advantage of that. Also at the Mayo Clinic, they found that their center was losing a half day of work per employee per year because they had no backup sick childcare. So they opened a sick child daycare center, and they found that the costs that they saved offset the daycare center's operating costs. So it can be done. I often like to say we can put people on the moon. We can figure out on-site childcare. It just needs to be an institutional priority.
Right. Well, speakers, panelists, thank you so much. What a fantastic session. We can keep going all day. Well, thanks to Dr. McArthur Keith. Thanks, Dr. Ostenfeld, Dr. Hagen, for this fantastic episode of the Coffee and Conversation, Balancing Parenthood and Career in Surgery. I learned a lot, and I hope our audience did as well. Stay tuned for part 2 of this episode to be aired on June 1st, 8 a.m. Central, so just a week from now. A huge thanks to the production team for putting this webinar together. As mentioned, the Coffee and Conversation programming will be brought to you quarterly. Be on the lookout for the next episode. I am your host, Dr. Rob Amajoy. Until next time.
Thank you so much. And I just would like to say, Dr. Ostenfeld's presentation was phenomenal. Every resident and fellow in this country needs to hear that presentation. Thank you for that. And I hope that you just share that with everyone. This was fantastic.
Thank you all so much.
Yes.